our last talk, we've saved the best for last, is a wonderful talk on adult congenital heart disease by my friend, Dr. Anne-Marie Valenti. She is Associate Professor of Pediatrics and Medicine at Harvard Medical School and heads up the Adult Congenital Heart Disease Program at Brigham and Women's Hospital and at Boston Children's. I know that we didn't get to questions in the previous talks. We'll have a few minutes for questions at the end of this session, and we'll try to get to the high yield ones at that time. So I'll hand it over at this point to Anne-Marie to take us home with adult congenital heart disease.
Thank you very much, and thank you for including us in this wonderful program. I do not have any disclosures, so I really have three objectives. The first is going to be to highlight some of the more common presentations we see of adults with congenital heart disease. And then I'd like to emphasize some of the key points for management of these adults through our recently published guidelines. And lastly, just spend a few moments talking about risk stratification for women with heart disease during pregnancy. So let's dive right in and look at these guidelines. The original guidelines for management of adults with congenital heart disease were published in 2008, and then they were revised 10 years later. And I want to focus on these because I think they provide a wonderful background for us to talk about that right now in the United States, there's more than 1.4 million adults living with congenital heart disease. And you are seeing more and more of these in your practice. And we use these guidelines as a template to work collaboratively for best care. One of the nice things about the revision was that the guidelines now recognize that one size does not fit all. And by that, I mean, you can have a patient with one condition, such as tetralogy of Fallot, who is very, very sick over time, may never have had a repair, live with cyanosis and advanced functional class and refractory arrhythmias. And yet you could have another patient born with the same condition, tetralogy of Fallot, who's an Olympic gold medalist, winning a ton of awards, and has a great functional capacity. So the guidelines now incorporate that by a functional class. And these new guidelines really do try to distinguish not only the type of congenital heart disease, but other factors called the physiologic class, such as does the patient have residual hemodynamic lesions, valvular problems, arrhythmias? What is their functional class? So with that, we're able to guide our therapies more specifically. Now, a common theme when you take care of patients with congenital heart disease is understanding that there are multiple systems that can be involved. This slide is just illustrating that. Thinking about in all comers with congenital heart disease, almost a third have abnormal lung function. Up to almost a half of those who've had an atriotomy with their surgery are going to develop some form of SVT, often much earlier in life than other adults do. Over 40% of adults living with congenital heart disease have at least mild renal impairment, and almost 10% of that's severe. Complex congenital heart disease patients have at least a 2.5% year risk or higher of having a stroke and other cognitive delays. And up to a third of our patients with single ventricle Fontan physiology have cirrhosis. Almost all of these patients have some abnormalities in their liver function. So just remembering as we care for these patients, the multiple organ systems that can be involved. And let's not forget as well the genetic consideration that goes along with congenital heart disease. This table is for your reference. This is a common board question if you're recertifying for boards, but understanding that certain conditions are very much associated with a higher risk of congenital heart disease. So for example, if you're seeing a woman in your practice who has short stature, web neck, other features, along with some aortic disease, a bicuspid aortic valve or coarctation, you're going to want to think about whether or not she could have Turner syndrome associated with infertility and other things. So just thinking about the importance of recognizing those genetic considerations. Now, before we delve into some of the more classical congenital heart defects, I wanted to take a few moments and discuss PFO. I think in our practice, this comes up a lot, and the evidence about closure of PFO for patients over time has changed. So we know that PFO is really present in 1 in 4 adults. This schematic is just showing you it is a flap between the upper chambers of the atria, and it's where this did not completely seal in development. And most people do not even know they have this. But if patients do have a neurologic event, such as a stroke or migraines, they're often worked up and found to have a PFO. And the classic teaching was that the majority of patients should not undergo transcatheter closure. However, in 2017, 2 articles came out in the New England Journal of Medicine which debated that theory. And when you look at these trials, there's some differences compared to the prior evidence. And that is, these are larger trials. They both include more than 600 patients, and they are a much more select group of patients. That is, these investigators isolated people with certain characteristics of the PFOs. They were moderate to large. In the closed study specifically, patients had to have an atrial septal aneurysm. And you can see here in this red line, these are patients that had undergone transcatheter closure. They had a better chance of not having a recurrent stroke at over 5 years compared to those that were on antiplatelet therapy alone. The reduced trial had similar results at a shorter time follow-up, but both of these follow-ups were longer than the traditional trials. So now it's thought that for select patients, really the young patients who had a cryptogenic stroke, that is not another reason to have had a stroke, and they have a large shunt or aneurysm that you can prove with no other evidence of cerebral vascular disease, no evidence of atrial fibrillation, and oftentimes we'll do a 30-day monitor to prove that, no evidence of a hypercoagulable state, they may be candidates to undergo transcatheter closure. So stay tuned, because this is a debate that goes on and on, but just thinking about the select group that these recent studies were done. Now let's move on and talk about a few specific congenital heart defects that you may see. I'm now going to use these diagrams that are box diagrams. The red blood is oxygenated blood, blue blood is deoxygenated blood, really just to illustrate some of these things. So here's an atrial septal defect. This is different than a PFO because the shunting from left to right allows for right heart dilation, as you can see here. You're going to pick patients up as adults with ASDs. These classically have palpitations, they may have dyspnea or some exercise intolerance. And on physical exam, they often have the finding of a fixed splitting of their S2 component due to the right-sided overload of the heart and the delayed closure of the pulmonary valve. When you do an EKG on these patients, they have an incomplete right bundle branch block and oftentimes have right axis deviation. That's for the more traditional common type of ASDs. For the rarer type called a primum ASD, they're going to have left axis deviation. And this next slide will explain why. This is just a schematic of the different types of ASDs. So you're familiar with the secundum. That's the most common. That's really in the central portion of the septum. That is the one with right axis deviation. A primum ASD is down at the crux of the heart where the AV valves are. It's almost always associated with a cleft in that mitral valve, and that causes the left axis deviation with the different vectors that are impacted. Sinus venosus defects are classified as types of atrial shunts, but they're really not in the true atrial septum. They're in the back wall. These are often associated with anomalous pulmonary veins. So important to recognize the different types of ASDs, because that last type, the sinus venosus type, is not easily closed in the catheterization lab. And when patients are diagnosed with this, they're usually going towards surgery. So when you're approached with a patient with an ASD, you can use the guidelines now to figure out the algorithm for treatment. Just starting here on the right side of the screen, the rarer type of patients who have right to left shunting or reversal of their shunting and Eisenmenger syndrome. They would be cyanotic. These are patients where you really need to confirm the diagnosis with an invasive catheterization and then think about advanced therapies working with your pulmonary vascular team. These are patients where closure would be dangerous, so we generally avoid that. The much more common set of patients here on the left side of the algorithm are those patients who have that left to right shunt. We then determine closure based on certain hemodynamic factors. We want to be sure that patients don't have increased pulmonary vascular resistance or pulmonary hypertension, and that the shunt is large enough that it's causing some degree of right heart dilation. You can see here in the algorithm, it's mentioning a QP to QS of at least 1.5 to 1. So that's pulmonary overflow. You then look for functional impairment. Many of these patients do have exercise intolerance. That's a class 1 indication for closure. The majority of secundum ASDs can be closed effectively in the catheterization lab. However, sometimes they do need to go to surgery. It's a class 2A recommendation even without functional impairment, as long as there's right heart dilation and no evidence of pulmonary hypertension. Going to the second group of shunts, let's talk about a VSD. You can see on the schematic here, a ventricular septal defect is also causing heart dilation, but this time the shunting happens more in systole, so you get left heart dilation. And it's important to recognize that most patients who've had large VSDs are hopefully been closed in childhood because they actually present symptomatic with heart failure and poor growth. So if you're seeing an adult with a VSD that's not been closed, it presumably is small and pressure and flow restrictive. That should not cause hemodynamic significance. However, if it is not restrictive, that's when you get into the Eisenmenger syndrome situation, which we'll talk more about. This is just an example of a pressure restrictive VSD in an adult, a still frame here of the short axis view, the aortic root. Here's a small VSD. When you put a Doppler across that, the key is going to be to look for a high gradient. That is, the velocity here was just about 5. So that gives a pressure difference of about 100 between the right and left ventricle. So that's telling you that the patient has low pulmonary pressures. So we want that high velocity jet across an unrepaired VSD. The last shunt, just to mention, is a PDA. You will rarely see this in adults. The schematic here showing this connection between the two great arteries. You could hear a continuous murmur. This small image is a reformatted MRA just showing the connection. Larger PDAs can cause left heart dilation, and we do close these usually in the lab, in the catheter lab, as long as there's no evidence of pulmonary hypertension. So this slide is just representing the different chamber enlargements you would see with various cardiac shunts, remembering that partial anomalous pulmonary veins, which you may see as well, would be the same as ASDs causing right heart dilation. I mentioned that there's a rare circumstance where patients with large shunts were not repaired in childhood, and that could lead to Eisenmenger syndrome. This schematic is just showing that progression of an initial VSD, which has a lot of left to right flow, but that flow causes pulmonary overcirculation and changes to the pathology of the arterioles in the pulmonary vasculature. So over time, the resistance increases. Then the shunt begins to become bidirectional and may even become exclusively right to left. These patients are very cyanotic. They have multiple complications. You may see them in your practice. Here's an image of one of our patients who've lived with an unrepaired VSD. You can see the clubbing here of the fingernails. One of the more common complications we see is that of hyperviscosity. These patients build up their red blood cells, they develop headaches, leg cramps, and oftentimes those are worse when they're dehydrated. They're also prone to various differences in their coagulation cascade, leading to more bleeding, thrombosis, and stroke. Over time, patients with Eisenmenger suffer from arrhythmias and heart failure. And when you see these patients, just think about abnormal cell turnover, because that's what contributes to the complications such as gout and gallstones and renal dysfunction and arthritis. These patients can succumb to sudden death. So these are patients we follow quite frequently in the clinic. Now let's move on and talk about a different right heart lesion, Epstein anomaly. You can see the schematic here is showing you that that tricuspid valve is apically displaced. The actual anatomic problem is that there's failure of this septal leaflet to delaminate from the septum, and that results in a large right atrium. And the symptoms for patients are really going to depend on the degree of tricuspid regurgitation that they have, or other associated lesions, such as a PFO or an ASD, which is common. Over time, as that right heart changes its compliance, you may shunt more blue blood into the red circulation and become more cyanotic. On exam, when you listen to these patients, you can hear the snapping of the S1. That's often called a Sale sign. And it's important to recognize the electrophysiologic consequences as well, that at least 20% of these patients have Wolff-Parkinson-White syndrome. This is just a still frame echocardiogram showing that apical displacement of the tricuspid valve in a young adult with Epstein anomaly. And on the EKG, a shortened PR interval, oftentimes a delta wave associated with WPW. Now I want to move on and talk about the largest group of patients that we see in the adult congenital heart clinic. And those are those with tetralogy of Fallot. It's the most common form of cyanotic congenital heart disease that's repaired into adulthood. You'll remember this as 4 lesions. There's pulmonary stenosis, a VSD, right ventricular hypertrophy, and an overriding aorta. There's a spectrum of severity with this, as I've mentioned in the beginning, but surgical repairs have really changed over time, where initially people had palliative shunts and then came back for repairs. Nowadays, we're doing primarily primary repairs. Many adults, though, live with significant complications of the initial repair and come back for pulmonary valve replacement later in life. So this slide just represents the complications that can occur hemodynamically in a patient with repaired tetralogy of Fallot. You can see here the VSD patch has been placed. The pulmonary stenosis has been relieved by placing a patch, but that leads to pulmonary regurgitation. Pulmonary regurgitation, one of the most common sequelae that we see in these patients. And the timing of pulmonary valve replacement is also a management issue that's changed and evolved over time. So it's important to work with your congenital heart center to help determine best timing for patients. I wanted to speak a little bit about one of the more complex lesions that you may see in practice. That's transposition of the great arteries. Now, recognize the definition of transposition is that the aorta comes off the opposite side of the ventricular septum than normal. So the aorta here is committed to the right ventricle. And this physiology is not compatible with life. You have to have some form of mixing as an infant. Here's an ASD. But very quickly, you need to go to some repair. Your older patients that are living with transposition are going to have some form of an atrial switch procedure. Those are named after the people that pioneered them, the Senning or the Mustard procedure. This graphic is just showing you what the surgeon has done. If you think about a Mustard procedure and you take, for instance, a pair of pants, and you put one pant leg up to the SVC, the other down to the IVC, and you drape that waist over to the mitral valve, it then gets the blue blood effectively to the left ventricle and out to the lungs. So the oxygenated blood, now red, returning to the heart, goes into the right ventricle. Here's the tricuspid valve and pumps out to the body. So this was remarkable because children that underwent this procedure are no longer blue. However, they live with the right ventricle pumping to the body. So the majority of them over time develop some degree of right ventricular dysfunction. As that right ventricle dilates, they get more and more tricuspid regurgitation. And these atrial baffles are prone to problems. They either become stenotic or have leaks, and they're a setup for atrial arrhythmias. That's the older patient with transposition. Starting in the late 1970s, the surgical repairs evolved, and we started to switch the outflow. That's this picture where you can see that the pulmonary artery and aorta have been transected and replaced. This is also noting that the coronary arteries have to be reimplanted. These are now young adults that are living with problems from that sequelae, such as branch pulmonary artery stenosis or dilation of that neo-aortic root. It can also be regurgitant, and occasionally problems with the coronary arteries. So these are patients that if they were to present for chest pain, we would very much look up ischemic causes. We have to think about that in these patients. One more point about transposition. This is a much rarer group, but someone you could definitely run into in your practice is a person who has lived with congenitally corrected transposition and may not even have been diagnosed until adulthood. If you take a look at this schematic here, remember the definition of transposition is that the aorta arises from the right ventricle. But here, the ventricles are also inverted. So blue blood coming into the right atrium, although it goes to an LV, gets out to the lungs. So there is no cyanosis at birth. However, many of these patients have associated lesions such as ASDs, varying forms of tricuspid regurgitation, or pulmonary stenosis. If they do not have associated lesions, they may not be picked up until they present with complete heart block. Another classic board question, this is the congenital heart lesion that has a 2% incidence per year in adulthood of complete heart block. So something to think about if you're approached with a patient with that. Another large group of patients that we see are those who have been born with coarctation of the aorta. You can see in this schematic here, this narrowing beyond the subclavian artery where the isthmus is. These are classically patients that present with hypertension. On exam, they're going to have a delay between their brachial and their femoral pulse and oftentimes have very diminished lower extremity pulses. There are multiple associations with coarctation that we need to be aware of, such as a bicommissural aortic valve, which is present in 50% of patients. That leads to ascending aortic dilation. These patients can get aneurysms. They can have consequences of the increased afterload, such as LVH. And there is evidence to show that people who have lived with coarctation develop coronary artery disease at an earlier age, and about 10% of them may have cerebral aneurysms. One other group of patients that we see that it's important to recognize are those with anomalous coronary arteries. These are just two still frame images showing you the less common but more lethal form. That would be a left coronary coming off the right. These we usually address and repair regardless of symptoms. The more common coronary anomaly would be the right coming off the left. This one's a little more controversial as to what to do. I show you the schematic from the recent guidelines, looking at, just to emphasize, the left from the right, we really are going to repair. The right from the left, we do other forms of ischemic testing, look for other issues as far as arrhythmias, and think about surgical repair. Many of these patients do still go on to repair, but it's a lower class of evidence. In the last couple minutes, I just wanted to share with you a couple aspects of pregnancy in women with heart disease. I know Dr. Seeley tomorrow is going to talk more about the medical complications of pregnancy, but as a cardiologist, it's really interesting to think about pregnancy as this great time of hemodynamic change. This graphic showing you the duration of pregnancy on the x-axis and the change in certain values as a percentage on the y-axis. So the red line is showing you plasma volume. Plasma volume definitely increases in pregnancy. It almost doubles. If you look at the timing of that, it really happens late in the second trimester, early third trimester. Compare that to the stroke volume here shown in blue. That goes up almost 30%, but that happens really early in pregnancy. Some women are just learning they're pregnant here. Heart rate also increases, usually about 10%. Women who've had heart surgery as a child may not be able to have that response though. So when you look at cardiac output, you can see that timing really mirrors stroke volume, and that can surge up to almost 50% pre-pregnancy values. When you look at this graphic, the one hemodynamic parameter that gets lower in pregnancy is the systemic vascular resistance. We think of the placenta as one of the best afterload reducers in the world. It's better than any ACE inhibitor. And that's why some women with certain cardiac conditions tend to do okay during pregnancy, such as valvular regurgitation. However, remember, during delivery, labor and delivery, and in the early postpartum period, all these hemodynamics change, and that's a time that's particularly vulnerable for women, especially as we're sending women home earlier and earlier after delivery. There have been several risk stratification scores developed over the past several years. This is a recent one done from the group in Canada, looking at almost 2,000 pregnancies in women with various forms of heart disease. About 65% of these women had congenital heart disease. The rest had cardiomyopathies, valvular heart disease, but they were able to generate a risk score, just highlighting the greatest degree of risk. For women in general, there's about a 15% chance during pregnancy that they would have an arrhythmia or some form of heart failure if they have underlying heart disease, but it's much higher if they've had a prior cardiac event, have a poor functional class, any degree of cyanosis, or mechanical heart valve. That gets the greatest weighting. Certainly women who've had ventricular dysfunction or left-sided obstructive lesions, as well as pulmonary hypertension or coronary disease, are in a special group. We specifically follow women with aortopathy very closely, and there are guidelines relating to that as well. So with that, I wanted to just go through two questions with you. I'll read the first one. A 30-year-old man is seen for systemic hypertension, not controlled on 2 medications. His blood pressure is 190/90 in the right arm, and he has diminished femoral pulses. Which of the following is not associated with his condition? We can start to key in our answers. It could be A, bicuspid aortic valve, B, differential cyanosis, C, risk of premature coronary artery disease, or D, intracranial aneurysms. So I'll give you just a minute to code in your answers. Okay, terrific. So varying degrees of answers, but what we're trying to recognize here is this particular gentleman has unrepaired coarctation. So what are the associations with that? There is an association with bicuspid aortic valve, premature coronary artery disease, and intracranial aneurysms. The correct answer here is going to be differential cyanosis. That is not associated with coarctation. Let me just explain that. Differential cyanosis is when you have cyanosis of the toes, but not the hands. As you can see here, there's actually clubbing of the feet. This occurs in a very specific condition in congenital heart disease. It occurs when a patient has had a PDA that over time has reversed its shunting, and there's Eisenmenger syndrome. And if you look at the color schematic here, the blue blood then goes down the descending aorta, creating cyanosis of the feet. However, the arms are supplied by the subclavian arteries that come off prior to the PDA insertion, so they do not get cyanotic. This doesn't occur with a coarctation, this differential. This is when we think about that is with a PDA with pulmonary hypertension. That was a tough one, and you guys did a great job. One more question for you. A 30-year-old woman presents with a history of childhood heart surgery. She is 28 weeks pregnant. Which condition would place her at the highest risk for maternal cardiac event during pregnancy? Would it be an unrepaired ASD with normal pulmonary artery pressure, mild pulmonary stenosis, which is unrepaired, repaired tetralogy of Fallot, or congenital mitral stenosis, having undergone a mechanical mitral valve? Give you just a couple seconds to put the answers in. Thank you for participating. It's true that any of these women are at slightly higher risk because they all have some form of heart disease. But I will stop there and tell you that the answer here is D. The majority of you got it correct. Congenital mitral stenosis with a mechanical valve is particularly challenging to manage in pregnancy. So just as a bit of information on that, women with heart disease have about a 15% incidence of having a maternal cardiac complication during pregnancy. These are oftentimes volume or arrhythmia related. Mechanical heart valves are included in that CarPreg 2 risk score that I shared with you. Complications can include thrombosis of the valve, dysfunction, endocarditis, stroke, hemolysis, bleeding, heart failure, arrhythmias. We follow these patients very closely. There are algorithms put out by the ACC and AHA about anticoagulation strategies for them. I've shared with you a few references in your handout for caring for adults with congenital heart disease. As a member of the Bach team, we would love to share these patients with you and collaborate. Thank you to all of my partners. Happy to take questions.
So, Anne-Marie, thanks so much for a wonderful overview of a complex topic for the boards.